should be continued. So what is the problem? We know that sodium valproate is a highly teratogenic drug, especially during organogenesis period. Not only that, but the antiepileptic sometimes we can restart after the organogenesis. But what is the problem with sodium valproate? In ideal setting, we have to stop throughout the pregnancy, because latter part of the pregnancy, if we are continuing valproate, what are the possible fetal adverse effects? They can have behavioral problem, neurodevelopment delay, autism is in there. But here, now what is the tricky point here? Seizure control cannot be achieved with alternative treatment. That means patient might get epileptic fit, so which has more adverse outcome. It affects the mother's life, hypoxia, aspiration, even a death, injury, or invariably it will affect the fetus. So certain epileptic types, sometimes we can achieve good control only with valproate. That is the preferred drug. So in this situation, what do you think? Fetus or mother or both? So it is true. If epilepsy is cannot control with valproate, no option, you have to continue. What are the general principles of managing epilepsy? We prefer monotherapy or polytherapy? Monotherapy as possible lowest dose. Okay. Option is A is correct. But if you have other alternative, or if you can stop, that is the option. Second one, so in epilepsy or any epilepsy, what are the things you should know as an undergraduate? In any medical disease, how I want to interpret or analyze the problem? There are disease can affect the pregnancy, and pregnancy can affect the disease. Other than the drugs. Okay, in epilepsy, you should know the drugs. That is your basic pharmacology plus the clinical application. Lamotrigine. What happened to lamotrigine? What do you know about this anti-epileptic drug and their pharmacokinetics? Certain drugs are enzyme, inducers are there, and some inhibitors are there. What's the problem with lamotrigine? It is other way around. Estrogen will increase the lamotrigine metabolism. So therefore, lamotrigine level not remain stable. It will change. Okay. So in the other way, I'll ask another question. So what happens if patient is on COCP at the same time if taking lamotrigine? What happened? What happened? What do you think? Patient simultaneously taking, for example, patient is on lamotrigine, we have start COCP. What happened? She will get pregnant or she will get fit. Estrogen will increase the metabolism of lamotrigine, so she will get a fit. So I have to increase the lamotrigine dose. At same as in pregnancy, most of the time we have to increase the dose of lamotrigine, especially latter part of the pregnancy. So lamotrigine level is not remain constant in the pregnancy. So these are basic. They are in RCOG guideline. Okay. Yeah. So prior to the session, there's a Google form, no? So some of you respond and ask about which guideline you should refer as a student. So there are SLCOG guideline, RCOG, and NICE. Okay, certain topics in the NICE, and most of the thing you can cover the RCOG. That's it. No need to refer other things. Option C, I think this is a very practical point. Every day we are discussing. Option C. Option C. If I in the labor room, this is a common practice here. False, true or false? Pethidine is a commonly used drug in our setting for pain control during labor. It's true or false? Namge, I know your name. Namge, yeah. True or false? True, yeah. So what's the reason? Pethidine, what is the active metabolite of pethidine? It converts to norepinephrine and it reduces the seizure threshold. So patient might get fit. So pethidine is what is the best? So therefore, what is the best option for pain management during labor? Right. Other thing is we should have good pain control. What happened? Sometimes pain itself, hyperventilation, pain can precipitate the fit. So epidural would be a good option. Okay, we cannot give pethidine. Yeah, it's clear. We will do little faster, then we can discuss at least 15. Yeah, option D. What's the place of magnesium sulfate in seizure? It's a it's a drug of choice in eclampsia. What's the answer? True or false? True. True or false? False. But if you are not sure about that, whether there is a eclamptic fit or breakthrough seizure in a non-epileptic patient or something else, then we can give max sulfate. But here the old type of seizure in the latter is not necessary, no, because a non-patient with is a regarding epilepsy. No, it's probably it's a non-patient with epilepsy. So if she get fit, so we can differentiate eclamptic fit versus like breakthrough seizure in epilepsy. Okay, it's clear. But if you are not sure about the diagnosis, then what is the option? You have to give the max sulfate. Okay, so until proven otherwise, you have to give max sulfate. But here since all the type of seizure in the latter part of the pregnancy, no need to give max sulfate in a patient with epilepsy. It's clear? Yeah. Now we are discussing the patient with epilepsy. E, you have to answer. Yeah. E, current group, no? E, what do you think? True or false? Now again same principle. What is the principle here? So drug which affect the enzyme inducers and enzyme inhibitors. E, true or false? Valproate. It's a very worrying drug, no? Valproate. What do you think? True or false? Huh? Mask girls under mask True or false? Valproate is a very problematic drug during pregnancy, but it is not an enzyme inducer. Okay, valproate is not an enzyme inducer inhibitor, so it does not affect the efficacy of COCP. Okay, so what are the principles? Now, what are the things you should know regarding epilepsy? Anti-epileptic drug you should know. That's a very potential topic for MCQs and the other general principles. Okay, a little bit about discussion. Yeah. So these are the enzyme induced. These are from the RCG guideline. Enzyme inducing drugs, carbamazepine, phenytoin, phenobarbital. It's a non-enzyme induced valproate, levetiracetam. We are increasingly use gabapentin like thing. Other than lamotrigine thing, we discussed that. estrogen can affect the lamotrigine metabolism. Okay, so yeah. Okay, anything you want to ask? Usually you will get okay, you can take photos, okay, but understand the principles. Yeah, yeah. So in the yeah. Yeah, that's a correct. That's a correct. But now regarding a patient with epilepsy, so eclampsia, they just not only get fit suddenly. So they have background history of preeclampsia, hypertension, these things. So in that case, but for example, here that question didn't mention about such thing. So this is one patient with epilepsy, she can get epileptic fit. So if there are no edema, no protein, no blood pressure normal, it is very, very unlikely to have a eclampsia. So therefore magnesium sulfate is not indicated. But if you are not sure, then we can give magnesium sulfate. Generally, that all the epileptic patients no need to give max sulfate. But if you are, for example, if patient uh, get a fit after a long time, or with the background history of hypertension, then there's a place. Yeah. Yeah, here, but the problem is the MCQ you can assume and mark. You have to mark depend on the history. Yeah, because these are very tricky. Okay. Yeah. Here didn't mention about her control, whatever things. Just mention so all type of she's in the latter part of pregnancy, whether she should receive max sulfate or not. It's not. That's why you have to read with the stem. Okay, if you read this stem alone, it is true. True, you can, but that's why you have to read with the stem. We are not checking this fact, we are checking this fact with the stem. This is a patient with epilepsy, now got a fit. Magnesium sulfate there's a place definitely, but all the patients no need to give max sulfate because max sulfate is not the option in that situation. Clear? So that's why you have to read with the stem. Hmm. Yeah, better to report to the neurologist, get the opinion, and we can consider the stopping or change into the safest route. If patient is having a seizure preceding previous within the previous 9 months, that is they have higher risk of seizure precipitant during pregnancy. Other cases we can consider. It depends on the type and all, seizure type. Okay. Okay. Yeah. What do you think? This is difficult. First one. Now I check with some of your pre-interns like Tumbal in our department, and this is little. These are easy. Real exam is a little tricky. Okay. Yeah. Do this. Cool. Sasmita cool. Yeah. Fourth good akina. Fourth good akina. Okay, this is a little easy one, no? We commonly encounter regarding instrumental delivery. Ventrous delivery can be performed even if the fetal head is above the scale spine. True or false? True or false? True or false? Yeah, false. What is the reason? Huh? Yeah, above the scale spine, that is high cavity. We do not do operative intervention for the high cavity in modern obstetrics, like either forceps or vacuum is we cannot apply. So if delivery is indicated, what is the option? Cesarean section. Okay, so this is false. Okay. B. Ventrous delivery is not recommended in the gestation less than 32 weeks. Huh? True or false? It's true. Okay, guidelines say 32. 32 to 36, you can test again a cautious, but less than 32. The premature babies, the skull bones are not formed well, it's very soft, and we cannot apply. Other thing is face presentation also. Face also we cannot apply vacuum because it's a suction. It might damage the soft tissues, eyes, mouth, and all. It's easy. See? 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 False. Yeah. That is, no. Draw. We cannot deliver vaginally because their presenting diameter is high, 13 centimeter. So option is cesarean section. Okay. Even a paraso, no, not the, it is immaterial. D. Udah tuh Malaysia. D. Sequential delivery. Here the sequential delivery has been defined. Forceps followed by vacuum is routinely performed. True or false? Routinely performed? False. Okay. We don't do the sequential delivery has lot of complication. Fetal as well as maternal. Maternal wise, they have high risk of obstetric anal sphincter injuries and tears. Fetal, there are hemorrhages, subgaleal hemorrhages, scalp laceration, intracranial hemorrhages, retinal hemorrhages. So complications are high. Okay. Sequential means we apply a forceps, then there are descent, then vacuum. Or other way around. Usually other way around. Initially apply vacuum with the descent to the introitus, forceps, but it is not routinely recommended. So it is on what is the recommendation? For example, if there are adequate descent with the first instrument, we can consider. But it's no, our intention is not to do a sequential delivery. E. E. Forceps can be applied to right occipital transverse position. Simpson's forceps can be applied to the right occipital transverse position. True or false? These are very easy. True or false? False. What is the reason? This patient need rotational delivery. So what are the methods that you can adapt? Vacuum, yes. Keel and forceps, and manual or digital rotation, cesarean section. So these are the one, but we cannot apply Simpson. Why? Simpson has a pelvic curvature and the cephalic curvature. With those things, we cannot rotate. There are high risk of injuries. It is not recommended. Okay. This is easy, no? මේක නම් පහම ගන්න පුළුවන්. අර D එක අතහැරියත් you can
do we just consider manual rotation before vacuum or keel and forceps?
it depends on the situation. Okay. For example, in a MCQ, if they were given a kind of emergency situation, it's the best one. Then keel. Okay, vacuum will take time. It depends on the scenario. Okay. So Cool. Good. Yeah. So this is a scale spine. This arbitrary line we consider as a 0. 1 centimeter below +1, +2 centimeter +2, +3 like that. 1 centimeter above -1, -2. Okay. So now in modern obstetric we do not intervention if head is above 0. That is called high cavity. So mid cavity is 0 to +2. Low cavity means +2 to +4. Outlet means the scalp is visible without separating the labium. So these things we can use instrument. Okay. So Simpson is a mid cavity forceps. There are Wrigley's is outlet forceps. Vacuum we can apply, but if it is above 0, we cannot apply instrument. Anything you want to ask about that question? That is easy. Okay. These are from the guideline. Let's say vacuum should be avoided less than 32 weeks. Sequential deliveries are not, it's not routinely recommended. Okay. Yeah, next one. Fourth is the photo. Yeah, this is a kind of a stimulation for you. So, currently, waiting to do prof. Yeah, it will be coming after August. August. Too speed, too slow. One you can discuss. Okay. So rhesus in rhesus negative woman, forget about the A. A. Option A. What's the reason? Yeah. So is already sensitized. There is no place for uh, anti-D prophylaxis. Okay. Already sensitized means patient is having antibodies. What is anti-D? It's the same, more or less same. Okay. There's no point in giving uh, anti-D to the sensitized mother. Okay. So in the other way, who are the candidate for anti-D prophylaxis?
Who are risk of getting but still haven't got
Yeah, Rh-D negative. That there are several types in the rhesus, no? Rogam, we are there's a trade name that is only for capital D, who are capital D Rh negative or unsensitized. These are the candidates. So if it is already sensitized, what are the things you can do? You have to monitor for fetal anemia, tetanus, these things, okay? But there's no place for anti-D prophylaxis. B, isoimmunization causes severe fetal complications in the first trimester. True or false? False. Why? What is the reason? Yeah, that's the reason. Red cell antigenicity is not well developed during first trimester. It will take time. Okay. Antigenicity means, so antigen, Rh antigen, it is a protein molecule situated in the cell membrane of the red blood cell. So antigenicity, the development of antigenicity, it will take time. During first trimester, they do not have severe complications. C, isoimmunization occurs following intrauterine death. True or false? True. Maryland. Death. Red cell Maryland. But it's a sensitive potential event. Okay. Sensitization will happen in case of intrauterine death. Sometimes it is more than the expected one. Okay. It's a potential IUD is a potential sensitization event. Okay. So I'll ask one question. So if it is a IUD, when are you going to give prophylaxis in unsensitized mother? When are you going to give? At the time of diagnosis or after the delivery? There's IUD. They have diagnosed IUD. Mother is Rh negative, unsensitized. I'm asking, when are you going to give anti-D prophylaxis? At the time of diagnosis of IUD or at the time of delivery? At the time of diagnosis. Okay. So red cells, it will take few days to deliver one thing, but that event has happened at the time of IUD. Okay. D, D, D. Let's see, where is D? D. True or false? Yeah. මේක තමයි ෂුවර් නැත්තේ. It is not the ductus venosus, it is middle cerebral artery, peak systolic velocity. Okay, not the ductus venosus. E, this you should know if I work in the ward. E, E, E. True or false? What is the practice? If it is mother is Rh negative, are we sending cord blood? If it mother is negative, we are sending cord blood. Okay. So ඒක ගැන හිතුවොත් මොකක්ද උත්තරේ? So do we consider we are rely on partner's blood group or the cord blood? Cord blood. So what is the answer? If unsensitized means we can give anti-D. Okay. During the postpartum period, regardless of the cord blood group, if partner is Rh positive. What is the practice in ward? There's a problem. What is the practice? Yeah, we waiting for the cord blood. If it is positive, we have to give. There are two reasons. One thing is we do not consider the partner's blood group. There are some practical issues. But the other reason, if it's Rh positive, there can be because it could be a homozygous or it could be a heterozygous. So depend on that, baby might be positive or negative. We don't rely on that. Okay. What is our practice? If mother is negative, we send in the cord blood. If cord blood is negative, cord blood is negative, cord blood is negative, if it is positive, that group NTD. Okay, that's a principle. We do not consider partners blood group, but it is important, but it is not very important to decide NTD. It's clear, no? So yeah, these are the potential sensitization events. These are from one of my lectures. Photos slide में था ना. एक photo करने पर carding कर लेती है ना वो कभी. Yeah. And this is the principle behind. What is the principle behind middle cerebral artery? So what happens in anemia? Viscosity goes, viscosity reduce. So it is inversely proportional to the flow. Flow rate will increase. So middle cerebral artery, this peak systolic velocity will increase. So you are in the current group, no? Do we have a patient? This kind of patient in the world? Our previous group, current group paper. So there's a patient with rhesus size. This kind of patient is there in our ward. Monitor is there, na? Yeah. So these are the some theoretic knowledge. Okay. Dose. What is the dose? Less than 20 to 50, up to 5. Okay. Okay. Next one. Tie. No, has stress as soon as possible. Okay. So what is the ideal time to give NTD? As soon as possible. So we can consider up to 7 to 2 days. Sometimes up to 10 days also there are some recommended, but as soon as possible we have to give. So otherwise what happens? This antigen will expose to the maternal immune system and antibody will form. So there's no point in doing NTD after that. Okay, usually we can take this. We just group in, rotate immediately. No, all months you are not giving. No, it will take. You should. If you take today, you can eat tomorrow. Or sometimes even today. What is other things? This is very expensive drug. So NTD, that's why we are not giving NTD. Prophylaxis we are not giving. Other countries they are. This is the cost effective reason. Okay, very expensive. But blood group very easy. Okay.
Negative.
Yeah.
Baby's blood group is AB positive.
Yeah.
Do we need to give NTD prophylaxis?
Yeah. So there are two blood group system. Blood group there are a lot of system. You have this ABO system, rhesus system, KL, Duffy other system. So now what is the problem with this? Is not the ABO incompatibility. This is a problem with the rhesus incompatibility. Mother is negative, baby is positive, RH positive. So what happened during delivery or during sensitization? There's a maternal hemorrhage. There's a mixing of blood. Maternal body exposed to the D antigen, which is not present in maternal body. So that is a problem. Then it will form antibodies and it will die.
Is there a possibility for hemolysis of beta persons for forming antibodies against beta?
Yeah, that is true. Because of the OBM incompatibility, that is there are some protective. That is correct. But it's not. We cannot guarantee. And the thing is, ABU system is a carbohydrate antigen. Rhesus is a protein. So protein can mount a vigorous immune reaction compared to the carbohydrate. Okay, so the point is correct, but it is we cannot rely on that. So relatively they have they are ABO incompatibility. Mother is O relatively because this due to the ABO incompatibility, some of the cells which lies prior to the sensitization, but we cannot guarantee. So therefore we have to give. Yeah, your point is correct. Yeah, regarding breech presentation. A. Success rate of ECV increased after 37 weeks. True or false? True or false? False. Okay. So what happened? Success rate decrease toward the 40 weeks. What is the reason? What is the usually in which gestation we are offering ECV? For primate 36 and multis 37. Why we are not offering prior to that?
Again, catch it.
No, we spontaneously baby might rotate. Okay, but after 36 weeks, chances of spontaneous version is less. We have to do the intervention. But what happened with advancing gestation? Breech will descend. With advancing gestation, breech will descend. So ECV failure, one of the main reason is difficulty dislodge the breech. If it goes into the pelvic inlet, so in order to turn, you have to dislodge, no? So with advancing gestation, success rate will become low. It's clear? Okay? It's not increasing, it is decreasing. එහෙම කියලා වැඩි හොඳට කියලා 33 ඒවා කරකනවද නැහැ. Okay? Because it will rotate spontaneously. Okay? Yeah. B. Breech presentation is associated with fetal abnormalities. True or false?
False.
True or false? That is true. Associated with. That is true, no? One of the reason for the breech presentation may be fetal abnormality. Okay? Not always, kill an associated. So what are the risk factors for breech? That is we are generally recruiting. What are the risk factors? There are maternal risk factors, fetal risk factors, and the lycovolute, placenta. These are the problems, okay? Polyhydramnios, oligohydramnios, low line placenta, uterine abnormalities, fetal abnormalities. Yes. Okay. Other reasons, so our postnatal pathology යන්නේ තින්ද? Breech එක කම්මුණොත් මොනවද කරන්න test? Pediatric team, they will load a certain test. Yeah, Otolani and Barlow test, and sometimes scan to exclude or confirm the development exclusion of teeth. Okay. Plus, if there are structural anomalies, they cannot turn. That is true. See? True or false? True or false? Me lazy one. Fourth years line halabon. Fourth years. True or false? See? True or false? Yeah, it's true. Okay. Forceps can be applied after. Okay. So head delivery, breech, the whole delivery process. We are not expect from you, but head delivery is a potential topic. Delivery of the head in a breech. So what are the methods? We can apply forceps. There are maneuvers, Morrison's Melly White maneuver, Bassett's maneuver. There are maneuvers. Okay. It's easy, no? I didn't ask about the forceps type. Forceps type is what are the forceps types? Pipers is the ideal one. Keeland also you can apply. Okay. Pipers in some I was there in Javardhanapura when I was registered as Pipers. It's more or less similar to the Keeland. Pipers are there. D. True or false? Yeah, it is true. Okay. What are the things we can do to improve the success rate of ECV? Tocolytics and certain cases epidural. Okay. with tocolytics, uterus is relaxed. It will be easy for our procedure. Okay, tocolytics, yes, correct. Salbutamol and turbidine are the options. IVO subcut. මේ ගයිඩ්ලයින් වල තියෙනවා මේ. In fact මේවා නම් පුරුවන් වෙන්න ඕනේ මේ මැඩම් එක පොතින් මම මේක ගත්ත එහෙම. ඒ කියන්නේ ප්‍රශ්න තීරණය කැලි කැලි එකතු කරලා. E continuous external fetal monitoring is recommended during labor in vaginal breech delivery. What is continuous external fetal monitoring? Continuous external fetal monitoring? Yeah, CTG. Okay, continuous CTG is whether it's indicated or not. That's a fact. True or false? Continuous CTG monitoring. What is the in a low risk pregnancy? How are we going to monitor the labor? Fetal well heart, intermittent auscultation. But certain situation we have to do the continuous CTG. So one of the indication for continuous CTG is non-cephalic presentation because they have risk of cord prolapse, especially. So that is true. External fetal monitoring is recommended. So what are the other situation we need extra this continuous CTG monitoring? This from the nice easy loku devalna. So in VBAC, yes, there's high risk of uterine rupture and all. It's called dehiscency. So these are in the FGR, yes. Non-cephalic, yes, there's a cord prolapse risk is there. Intrapartum risk, like if mother is having fever, maybe choriamnitis, meconium, then these two are important. Use of oxytocin and epidural. It's indication for continuous CTG monitoring. Why epidural? Oxytocin you can think no, it can lead to hyperstimulation and all. Why epidural? My patient is epidural. Yes, hypotension, maternal hypotension can cause fetal hypoxia. Okay, so it's clear, no? Some of the nice, and you should know these things can be checked. Not all, few. Shall we move? Oh, good. Speed වැඩි ස්පීඩ් එක වැඩිද නේ තව ගොඩක් කරන්න 9 විතර ඉවර කරන්න Shall we discuss? Yeah. Yeah, today also Gihan sir also planned to join, but due to some practical issues, sir has went for some because he's he involved in common MCQ. There's a kind of scrutiny. That's why. Yeah, this you should know this. It's a common topic. Cervical screening and cervical malignant, especially pre-malignant lesion. A. 16 and 18 account for the majority of cervical cancer cases. Beta cancer. Yeah, beta one is regarding cervical pre-malignant and malignant lesions. Okay, HPV 69 account for the majority of cancer cases. True or false? That you should know. True or false? True. Okay. B. Corn biopsy is preferred over LETs when glandular involvement is suspected. This you can work out an answer. If glandular cells abnormalities there in a smear, which kind of biopsy we should perform? So if you are performing a biopsy, we have to harvest the glandular epithelium. There was no point. So which biopsy is preferred? So where is the glandular epithelium? Outer one is squamous, stratified squamous. Inner or toward the uterus size is glandular. So sometimes we have to take a biopsy with a good length. So what is the preferred option there? Cone biopsy. Let's we are using loop now, some 25, this is small amount, but in cone we can cut and we can take a biopsy. So if it's a glandular epithelium, it's clear now. So glandular involvement means glandular cells are in the deep in the cervical canal. We have to take a deep biopsy. Okay, for that cone is preferred. C. HPV vaccines are live attenuated vaccines. HPV? Yeah, it's not a live attenuated. Vaccine has formed against the L1 capsid protein. Okay, so not a live attenuated vaccine. D. C nang is that fact you should know. D you can mark. Let is contraindicated woman desiring future fertility. True or false? Let's is contraindicated. And women who is having the fertility wishes. True or false? True or false? So I'm asking other way. Now patient is having a premalignant lesion. She is having a pregnant fertility wishes also. How are going to treat? You have to take a biopsy. Okay, let's not the cone. So cone, because we are taking a large part of the cervix. It is not contraindicated, but the potential complication can happen like preterm labor, preterm rupture of membrane. She may need clutch, progesterone. These things can happen, but it is not contraindicated.
Can you say cone is contraindicated?
Hmm?
Can you say cone biopsy is contraindicated?
No, again, it's a problem. For example, gangrene movement, you can do it on even sometimes we have the trachelectomy. With the trachelectomy, as a treatment option, we are removing this. Depend on the risk and it's a way in the risk and benefits.
So as per say, no procedure is contraindicated.
Oh, එහෙම විතර අහු කරන්න පුළුවන්. Okay. All them වැරදි කියලා එහෙම ගහන්න බෑ.
Have risks but not contraindicated.
Yeah. You have to think. Okay. එහෙම කියන්නේ for example, placenta previa is a contraindication for vaginal delivery. Not all is contraindicated. Okay. Yeah. E.
Yes.
HPV, high risk HPV testing can be used as a primary screening tool. True or false? True or false? What do you mean by primary screening tool? That means that is alone, HPV alone can be used as a screening tool. True or false? Yeah, true or false? True. So that is a trend. Now trend is HPV, high risk HPV DNA testing. PAP is in a Western country. It is not the. It is going away. It's, no, Sri Lanka's pilot projects are there. So, but in future we can implement that. It's a kind of a PCR. We have adequate. We have enough PCR machines. Okay.
So in guidelines there are protocols and algorithms
Yeah.
for screening.
Yeah.
So for MBBS we should be
In the
also
Sri Lankan guideline, they mention about the screening based on the HPV DNA and screening based on both. They have mentioned in Sri Lankan guideline also.
there are both.
Yeah.
Should we also know about the
No need to algorithm. මේක දන්න ඕන algorithm. Okay. ඒව ඕනේ නැහැ. ඒව ඕනේ නැහැ. ඒක very difficult. Okay. No need to. ඒව අහන්න. But you should know the principle. For example, in this is now what are the things you should know in a pre-malignant lesion? You should know the next step. For example, if it is a high seal, what is the next step? Low seal, what is the next step? The next step you should know. Then other thing is the screening. This fact, okay. Next step in SBS. Yeah, for example, high seal, what is the next step? Colposcopy. Like that, these things you should know. It's clear? Okay. Yeah. Go home. Yeah. IPL final එක නේද? ඉවරත් තියෙන්නේ. So you're allowed 4 years. It's difficult, but it's a good idea. So this is the standard. Real ones sometimes even more than this. Amaru. Yeah. A. Regarding twin pregnancy, all dichorionic twin pregnancies are dizygotic. True or false? All තිබ්බොත් false. Always තිබ්බොත් false. All තිබ්බොත් false. Now, what is the reason? All dizygotic twins are dizygotic. True or false? All dizygotic twins are dizygotic. All dichorionic twin pregnancies are dizygotic. Huh? False. So dichorionicity can happen in both monozygotic and dizygotic. Okay. For example, remember all dizygotic twins are dichorionic. That is true. Okay. It's clear now. So dizygotic means they are genetically different. So they can have a common placenta. Definitely they become dichorionic, diamniotic twin. But in monochorionic, what happened? Depend on the cleavage time. If divide very early, it become dichorionic. So they will have two placenta, but genetically they are same. B. IVF increases the risk of monochorionic twin pregnancies. IVF increase the risk of monochorionic twin pregnancy. True or false? Generally, IVF increase the twin pregnancy. IVF is a risk factor. That is true. So monozygotic, that's a problem. It's true or false? Monozygotic means what is monozygotic twins? At the beginning, there's a one zygote. So during the cleavage process, they divide into, they become two individuals. Okay, independent individuals. Independent, they become two individuals. Can it happen in IVF? Yes, it can happen, because IVF we are doing the only the fertilization. So IVF is we facilitate the two sperm and ovum to meet. After that, uh, it can happen. So it is true. It's clear now. And IVF increase the risk of monochorionic twin pregnancies. That is true. Yeah, it's increased more than that. Yes, it is increased compared to the background. Is it difficult? So during IVF, it's a non-risk factor. It increases the twin pregnancy, including both dizygotic and monozygotic. Okay. D. D ne මේක C වෙන්න ඕනේ නේ. මොකද D. Okay. First trimester ultrasound is the most reliable method of determining chorionicity.
Can be done, but it is not.
True or false? True or false? Huh? First trimester ultrasound is the most reliable method.
Sometimes
How are we going to determine chorionicity?
ultrasound
Ultrasound scan. What are the signs?
and the sign is
Oh, excellent. So when are we going to do that? First trimester. So that is true. Okay, that is the most reliable method. But if you are advancing the gestation, we cannot use the lambda and T sign is not reliable. So
sometimes in the first trimester scan it is missed, but sometimes
no, best you can predict when fetus when the pregnancy is small. In the advancing gestation, you cannot determine. All looks like T sign. That's a problem. Okay, that is the best indicator. That's the when I'm managing twin pregnancy. That they also told, the recent group also recently I told. What is the important thing in a twin? When I'm managing a twin, what is the important thing? Determination of the chorionicity. So chorionicity, you should know. Twin means you should know the chorionicity. Management, time of delivery, mode of delivery, complication, everything will determine by the chorionicity. E. Vaginal delivery is contraindicated in monochorionic diamniotic twin pregnancy. E. Vaginal delivery is contraindicated in MCDA. True or false? Okay. Yeah. True or false? It's no, it's not true. It's not contraindicated. Okay. It's not contraindicated, but there are certain problems can happen. What is the main factor which determine the mode of delivery in twin? MCMA, better to have a cesarean section. Other twin, MCDA and the DCDA, what is the factor which determine mode of delivery? Current group monitor. Yeah, yesterday we had the presentation of the first twin. Not the chorionicity, there are certain problems can happen, but it's not contraindicated. F. This you should be able to answer. Prenatal screen is not applicable. That means we cannot use prenatal testing for twin pregnancy. True or false? False. Why? Yeah, NT you can මොකුත් දන්නේ නැත්නම් NT කරන්නත් පුළුවන්. Biomarkers there can be interpreted. Again, biomarkers also you can do, but definitely NT won't be a problem.
LPDNA can also be,
Now recommendations are there.
but both
The problem is we should know the core university.
oh,
Okay, if core university is confirmed, okay, but anyway, but we can do the NT. It's not applicable, it's false. Prenatal screening, yeah, that is true. Yeah, generally because they can have a high risk of cord problem and all, then preferred option is cesarean section at 32 to 34 weeks. So other reason is 32 to 34 we cannot because they are labor is they are unless spontaneous labor they are not in labor. Okay, so MCA MA delivery is usually cesarean section. What's the time? 32 to 34. Okay, in twin what are the things you should know? Coronicity is the most important thing, and the time of delivery they can we can question, and the complications, especially complication in the monochorionic twin pregnancies. Okay, and pathophysiology like this thing. Okay, fourth years na amaru wagene. Yeah. Yeah. So SPA time වෙලාව නැති නිසා. But I have an interesting question. Make කරන මේ question එනවා.
I'm trying to get it through. This one MC if it's there.
MCMA generally cesarean section is a preferred option. Contraindicated generally is a preferred option is we can help MCDA. Yeah, MCDA is not contraindicated. MCMA, other thing is MCA we are delivering 32 to 34 weeks. So by that time they are not in labor. So preferred one is unless it's a in advanced labor we may consider vaginal delivery, but the preferred option is cesarean section. It's contraindicated එහෙම කහන්න නැතුයි. It's clear. The two reasons.
Primary screening tool
Yeah. නෑ නෑ මේ තියෙන combination එකක්. ඒකේ guideline එකේ දීලා තියෙනවා this is a combination both HPV and the PAP. Oh, other one we can use the PAP only. That's why we are currently practicing. Other one is we can use HPV only. So primary tool is correct. HPV only means sometimes we might have to do the PAP, but it does not mean primary clinic in කියන එක නෙමෙයි. Yeah. The other thing is sensitivity is very high in HPV DNA. Perhaps around 50% are 80-90 වගේ තියෙනවා.
For glandular we use the hormone because skip lesions also.
Skip lesion also can be there. Plus the glandular means it's in your in the transformation zone. Transformation zone එකට උඩින් තියෙන glandular cells. So we have to harvest that area. So that means we have to ලොකුවකට හරන්න ඕන.
Sir, what about if we do NLPS twice?
Yeah, that is other option. ඒකට කියන head top කියලා මම කිව්වේ. ඒ කියන්නේ සාමාන්‍යයෙන් කියන 25 mm. You can cut one go then head top කියන මේ අදින්න පුළුවන්. Like you can go එකක් කපන ඊට පොඩි loop එකකින් මෙහෙම. That is option. Other thing is we can straight away do a large cone. Yeah.
breast done for primary surgery, it's by 36 weeks,
Yeah.
and for multi, it's
Yeah.
by 37 weeks. So, if we do ECV before that, then the success rate of ECV is again low.
Yeah,
Because of unstable.
before we no need to do that because there's a higher risk of spontaneous work. Yes, so therefore we do not ECV for very less than that period. There's no point. It will spontaneously, but problem is after like 3%, like after 36 weeks, spontaneous version to cephalic is very low. That's why we are offering ECV. Yeah.
So by 37 weeks, it's like the success rate is very high. So if it goes beyond 37
Again, success rate drops. Yeah, because of the engagement. Okay. Yeah, this one. There are some MCQs based on this medical legal issues. A, use of donors is illegal in IVF in Sri Lanka. Sri Lanka again. True or false? True or false? Would they වැඩ කරන්න මේක ගහන්න පුළුවන්. ඕන තරම් දෙයක් තියෙනවා but it's a treatment option. It's not illegal. Sperm donation, egg donation, it's not illegal, but problem is we don't have proper laws. That's a different thing. Regarding IVF, we don't have laws. Like what is the commonest thing? Sometimes multiple pregnancies are risk. So we don't have proper law to how many embryos we should transfer. So there are issues are there, but however, use of donor egg is not illegal. That's a treatment option for certain individual. B, for postpartum, by using the husband's consent is needed. Huh? Huh? B, true or false? False. Even for any contraception, husband is not needed, but IUCD is a reversible one.
When we are doing the formatting gene work,
Yeah, practically IUCD will nangu. LRT is sometimes we are taking. Yeah, because of some there are some issues there, no? But it's not mandatory. It's a woman's right. Karana, because problem can right.
for the LRT,
Yeah.
the husband consent is not required as
So there can be problems can happen with the like Shafi case and all. So that's why. But it's IUCD is irreversible. See, see, see that you should know. But fetal indication we cannot do. But certain maternal indication like heart disease complicating pregnancy, severe renal disease complicating pregnancy. So that is we can consider it is a MDT decision, but there are legal framework is there to consider TOP, termination of pregnancy. D, D, D. In case of IUD, pathological postmortem, can we do without parental request? True or false? If you work in the ward, you should know those things. We cannot do that. For the postmortem, babies, to cut the baby, we need parents' consent. But placenta we can say. We cannot cut a baby without parent consent, whether it's a death or life. E, E, female genital mutilation. Bhutan, you have to learn those things. So if you are here for the exam purpose, I don't know about the Bhutan. E, it's true or false? Oh, Nidhimata Itakkarne. Who is she? Yeah. You know the story, no?
I will explain to you this at first hand. I was 7 years old. I was outside playing with my friends when I was picked up. My clothes were ripped off and I was taken to a room where 3 women waited with blades, scissors, and all tools. These women were not doctors, nor were they medically trained, just tradition passed down through generations. They cut off my clitoris, the part of my body meant for womanhood. They then sliced away the inner labia and the outer labia. I remember I screamed in pain because during the procedure there's no anesthesia used, no comfort, only blood and loud silence. I remember crying and begging, but the woman told me to be quiet, to be brave, and to be proud, as that was part of our tradition. Once the cutting was done, my skin was stitched back together with thick thread or thorn, leaving only a tiny part of hole, barely enough for urine or blood to pass through. This process is called infibulation and is one of the most severe forms of FGM. After the procedure, I was laid in a dark room with my legs tightly tied together.
So, is it practiced in Sri Lanka? Female genital mutilation. Is it practiced in Sri Lanka? No. That's a problem. We don't know, but
Yeah, and used to know. And I would
we don't know, but Suddha knows that. In RCOG guideline, you mentioned outside Sri Lanka. This RCOG guideline. It is practiced in our country, certain part of the country, because of this cultural practice. So, what is the answer for that question? What is the E? What is the answer? Legalized in certain district in Sri Lanka. True or false? It because it's a community cultural practice. That her speech she mentioned that she's from Somalia. Almost 98% of the females are they have this procedure. Remaining two are infant and the newborns. That means almost all it is in Somalia had this procedure. What about Sri Lanka? In certain district, during the true or false? Common sense එක මේක ගහන්න පුළුවන්. අර ඡන්ද කාලෙ මොනවද කියන්නේ? ස්වෛරීත්වය රටේ බෞද්ධිකකරණ නිසා එක රටක් එක නීතියක්. දිස්ත්‍රික් වලට කියලා වෙනම නීති නෑ. That is false. So, it is false. Okay. Problem is we don't have legal framework. It is we can punish them. This point I discussed with the forensic department also. For example, if I encounter a child with the female genital, it's a violation of, it's a kind of a child abuse plus violation of human right. It's a punishable offense. But we don't have a proper legal framework. Anyway, it is not legalized. District means anyway it's true. Okay, we'll move to the SBS. We'll finish by 9.
yeah.
Yeah. SBA. Okay, now how are we going to do SBS? There are a lot of methods are there. I think you know that. No, what are the SBA? What is the generally almost all answers are correct. All answers. So many answers may be correct, but among that you have to select the best one. Okay. obviously where are the answers then. Okay. Now what is the, how we are going to do that? What are the ways? Now up to now we have done a lot of exams. No, there cover test scale. That means without looking at the answers, you can guess the answer. Then you can recheck in the whether it's present in the answer option. Otherwise, what happen if you read the option and if you go to the question, what happen? ඔක්කොම හරි වගේ. එතකොට උත්තරයක් හොයාගන්න බෑ. Okay? So now Gyan's asked to practice this. That's okay. Try in the cover method. So what are the important points in this MCQ? SBA. 27 years nulliparous, the pelvic pain, mild vaginal bleeding and pregnant, 8 weeks, adnexial mass with small amount of free fluid in the POD, no IUP. Okay? Beta HCG over 5,000. So what is the option? So what is the diagnosis? What's the diagnosis? Diagnosis? Ectopic pregnancy, ruptured or leaking. Okay? Ectopic pregnancy. What's the why? What's the reason for offering beta HCG? What's the reason for offering beta HCG? For the diagnosis or something else? Yeah. For the diagnosis, beta HCG play a role in diagnosis of pregnancy of unknown location. Now here there's adnexial. What is the why we are doing beta HCG? To decide management. So there are what are the options for ectopic? There are expected management, medical management, and the surgical management. Okay. To decide initial beta HCG is important, plus clinical condition plus the beta HCG. So what is the option? This can yeah. What is the option? Now she is having a pain, mild pain, free fluid also, beta HCG also high. So how are we going to decide this treatment? Usually for the ectopic, either medical or surgical, conservatively very rare. How are we going to decide whether hemodynamic stability, what else? What are the factors you should consider? Either medical or surgery. Yeah. Hemodynamic stability, okay. Rupture. What else? Huh? Yeah. Initial HCG value. Initial HCG value. Patients willing to follow up. For example, we are given if we are given methotrexate, patient need to come and patient should have repeated beta HCG assessment. Okay. So here point is it's more than 5,000. Which one is best? Surgery or medical? Surgery. What is the answer? A pain, right? Yeah. What is the answer? Answer? E. Okay? C, no? Answer is C. If you මුලින්ම answer බලුත් ඔක්කොම හරි වගේ ඒකට උත්තර හොයාගන්න. Okay. So what is the place repeat beta HCG in which situation? In 48 hours? Pregnancy of unknown location. These options are wrong. Okay. So what NICE says is NICE say we can offer medical management if patient is having these criteria. That's a, for example, if patient is willing to follow up and no significant pain, මේක නම් ඔයගොල්ලෝ දැනන් ඉන්න ඕනේ. No viable visible heartbeat. If the heartbeat is visible, option is surgery. And the initial beta HCG less than 5,000. Okay, these are the criteria for medical management. It's clear? Okay. So yeah.
Without parental request, we can educate the parents about the importance.
Yeah, that is their concern. So that means you are counsel for that.
Parental request means parental wishes.
No, request mean request can I'm did
Yes, rather than request. So then we can educate the parents about the importance of
yeah
sleep, and then we can do
yeah. I got into the request kid. Yeah, the problem with the word, you know. Consent is the best. No? Yeah.
that MCQ question. Is it constrained with provision?
MCMA ಏನು ಕೇಳೋಣ preferred one is urgent. There are two reasons. One thing is MCMA we tend to deliver early, 32 to 34. By that time they are not in labor. Generally we are not doing inducing and all. That's one thing. Other thing is MCA having a code problems. Okay, almost all MCA twins are codes have get yes umbrella again. So they have a high complication interpartum. So these two reasons they are not offering. For example, confined in for example, if patient is with advanced labor, then no need. Then we can consider. That's it. What is IVF? Yeah, general population to very general population for example, general spontaneous pregnancy agano IFC agano. This is IFC to in a very general IFC monoclonal transfer. I'm not sure about that. But generally twins are increased. Okay. So what are the important points in this question? What are the important thing? What is the important point? What is the important point to decide to get an answer? Current pregnancy otherwise uncomplicated. Okay. What else? Oh, what is the important point? Huh? What is the important point? GBS positive UTI in early part of the pregnancy. Okay. Okay. So these are things. Now she's at 40 weeks, pregnancy otherwise uncomplicated, and she had a GBS culture positive UTI at 20 weeks. What is the option? What is the answer? Huh? What is the answer? N. Huh? BQ Mukad? Prophylaxis, yeah. What is the answer? Yeah, answer is, so the fact here check in is you should know the indication for interpartum antibiotic prophylaxis. A false, we do not do that. C also false, false, false. Answer is B. Okay, so you should know the indication for interpartum antibiotic prophylaxis. What are the indication for interpartum antibiotic prophylaxis against GBS? Preterm labor, preterm labor and the pre-labor rupture of membrane. Interpartum, if mother develop fever during labor, so most likely it is due to chorioamnitis. One of the common organism cause chorioamnitis is GBS. So you have to go GBS. Other thing is the GBS UTI in current pregnancy and GBS colonization. These are in the guideline. Okay. GBS you should know, because what's important? Why GBS? It causes neonatal sepsis and neonatal meningitis. So that is it's a significant problem. You should know about GBS. We'll go to the next one. It's difficult for you, no? It's difficult. have you had lectures?
Some
Chaturasat kara na?
topics.
Chaturasat kara na?
Yes, not regarding these things.
Yeah, you have time. But what you can do is you have to prefer guidelines rather than this age. Better read the books, the theory, like textbooks. The 10 teachers. Yeah, you have to do that one. When you are doing the appointment, you can refer guideline for the management part. But if you read guideline only, you cannot do MCQs. You should know basic knowledge because guideline will change time to time. But you should have a understanding about the condition. Then you can do MCQ with the minimal knowledge on the guideline. Okay, but don't read guideline alone. It won't help. It will complicate further. Yeah. What is the answer? 35-year-old, 34 weeks. What is the diagnosis here? What is the diagnosis? What is the diagnosis? Huh? What is the diagnosis? CVSGA. What is the diagnosis? Huh? You should know the diagnosis. Yeah, today Tumala told me you should know this Delphi consensus. What is Delphi consensus? Delphi අහලා තිබුණලු ඔයගොල්ලන්ගේ කලින් පාර. So this little theory I am skip this thing. What is FGR? This මේක අහලා තිබුණලු last time. Delphi thing, okay? This is in the guideline. You should know this thing. If it is less than third centile, what is the diagnosis? Less than third, irrespective of the gestation, it is FGR. Okay? So this now, what is FGR? Fetal size. That means estimated fetal weight to AC less than third centile. That is FGR. Or if it is less than 10 centile with Doppler abnormality, again FGR. Okay? Clear? Any fetus less than third centile, that is FGR. If it is other thing is less than 10 plus Doppler abnormality, again FGR. Now what is the diagnosis here? Less than third centile, that is FGR. Okay. What are the reasons for FGR? What is SGA? Little. This is very pattern. What is SGA? Small for gestation. What is small for gestation? How are going to diagnose? ACO, estimated fetal weight, less than 10 centile. That is SGA. ACO, estimated fetal less than third centile. FGR. That means under the SGA is a part FGR. Okay. So plus other possibilities less than 10 centile with Doppler abnormality. So SGA, what are the possibilities? That means when if you plotted the growth, it is less than the 10 centile. What are the possibilities? This concept is important. That's why I'm no point in talking theory here, but this concept is important. What is SGA? Estimated fetal weight to abdominal circumference less than 10 centile. What are the possibilities for that condition? One thing is FGR. Other possibilities? Constitution small or abnormal baby. Okay. So yeah, abnormal means this is a kind of abnormal baby. Structural abnormality, chromosomal, these things. What is generally, what do you mean by FGR? Baby cannot achieve the genetically or given or genetically potential growth due to some reason. So reason could be these things. That means these babies are abnormal. For example, if baby is having a congenital infection, baby cannot grow as normal. Other thing is, if the placenta is problematic one, baby is normal, but baby cannot get adequate nutrition and oxygen from the placenta. Again, baby becomes small. Clear? So you should differentiate those three. Clear? Here, what do you think? This baby is Doppler abnormalities. Would you expect Doppler abnormalities in this category? No. They are normal. But the problem is small. Why small? Because of the genes. But these two categories, small. Why? Either due to abnormal baby or abnormal placenta. Clear? This concept is very important. So here, what is the answer? This type of question you will get in your exam. What is the answer? Now this baby is having FGR. So having a is already hypoxic baby. Already hypoxic baby. So you need surveillance. So you have to assess the fetal well-being. What is the best one? What is the best one? 34 weeks. What is the ඔක්කොම හරි ඉතින් බෙස්ට් එක තමයි අහන්නේ ඔක්කොමගේ හරි ductus venosus no after 32 weeks there's no much place in ductus that is out MCA so MCA is the option. What is the pathophysiology? Why we are assessing the MCA adopter? Now what happened? Now this baby is chronically hypoxic. Okay. So what happened if blood supply further reduce? What is the fetal adaptation? What is the fetal adaptation? Yeah, we want to preserve the blood supply to the vital organ, brain, heart, and adrenal, so especially brain. Okay. So baby is maintaining blood constant perfusion to the brain while reducing the blood supply to the other organs. So what happened to the resistance in the middle cerebral artery? Resistance increase or decrease? Resistance decrease. Okay. So that's why we can assess the middle cerebral artery resistance, that is PI. Yeah. Clear? එකක් විතර කළා නතර කරුනේ theory. It's clear now? Yes sir. This is nice slide, but I will skip. මේ වෙලාව හරියනකොට තේරෙන්නේ නැති කිව්වා. Yeah. Gynecology one. This is the type you will get, okay? You will get a large stem. In the exam, you will get a large stem and the answer options. Okay. RCB. Kito 14 නේ. 200 ගහයි නේ. කොලියද? කොලියද? අරුන් එදා ගෙවුවනේ 204ක් ගෙවුවනේ ශ්‍රේෂ්ඨය. ඔව් 99 මීටර 100ට. Yeah. Okay. What is the answer? Again, in this SBS, there's a one fact. You should identify that fact. Most of them SBS, there's one fact. If you identify that fact, you can select the answer. What is the key here? What is the key here? Without ATP, any other? What is the key here? endometrial thickness 5 millimeter. But anyway, we know the diagnosis is endometrial hyperplasia. So anyway, we will expect high thickness. What is the key here? Now think this patient, menopausal lady, present with bleeding, and we did a pipette. It came as endometrial hyperplasia without atypia. Okay. So what is the management? There are management options are there. But what is the problem here? While we are investigating or we are doing the scan, we found a scan, we found a ovarian cyst fairly large with septation. So how is it will alter your management? Will it alter your management? Yes. Why? This is a menopausal lady with this kind of this much large cyst with a septation. It may be it may have in a concurrent ovarian pathology also, even a malignancy. So what is the next step? Ask the next step. What is the next step? What is the next step? What is the next step? Huh? What is the next step? Huh? No, that is wrong. So answer D is wrong. Why? For example, in case of ovarian malignancy, treatment is not the hysterectomy and oophorectomy. You have to do momentectomy and etc. But the next, ask about the next step. First, you have to differentiate whether it is a malignant or not ovarian cyst. What is the next one? Tumor markers. And you have to calculate tumor marker RMI. Okay? Clear? So next step is in this kind of patient you have to do the CA125. Answer is E. Clear? Okay. So here point is this one. If this one is not there, then D. Then D. Okay. Anyway, she needs hysterectomy. That is true. But at the same time, she is having a ovarian pathology. We need to sort it out. These are practical things. Okay. In the ward, we may encounter these kind of patients. Yeah. Guy ne දෙයක් විතර නාමයට කොහොමද නතර කරන්න ඕනේ?
Without therapy, do we need to do the hysterectomy or can we do
Yeah, postmenopausal, what is the option? Yeah, LNG is option, but yeah, you can consider LNG. But the thing is, if the BMI is high, they need annual biopsy until definitive treatment. Until definitive treatment is hysterectomy. Okay, postmenopausal usually, yeah, LNG is the first option, especially premenopausal LNG is. Okay. Yeah. What is the answer? Yeah. What? Yeah. What is the answer? What is the best management? What happened is a menopausal lady during routine checkup in the scan. There's a solitary fibroid, 5 by 4 by 4. Solitary fibroid. Patient is asymptomatic. What is the best management? Best. What is the best? Hmm? What is the best one? These things you should know. The MCQ. What is the best one? What is the වැඩම්ම නැති ගොතන? වැඩම්ම නැති? What is the answer? MRI. Why you want to do the MRI? Yeah, you say MRI. Why do you want to do the MRI? Best. Okay. The PET CT. Yeah, MRI, there's a place. What is the place? If it is a solitary fibroid, what is other possibility? One fibroid leiomyosarcoma. Okay, but here there are no much evidence to say it is leiomyosarcoma fibroid. So what is the best option? What is the best option? E. What is the best option? You should be confident. Reassure. Answer is reassure. Okay. Okay. Because postmenopausal lady fibroid asymptomatic, uh, it won't be a problem. Okay. Reassure is the answer. Okay. Other hysterectomy බොරුවට කරන්න පුළුවන් but I think ඉවරයි මං හිතන්නේ. Yeah, last one. SBS are a little difficult. Okay.
Can we leiomyosarcoma don't we need to repeat?
No, repeat is not there. That's if it's leiomyosarcoma, only the marre. Okay, no kind of follow up is not there.
Even if it is a fibroid, can we go for
Sorry? No, that's not option. Why? What are the things we can gather? Because other things, fibroid do not evolve into leiomyosarcoma. Leiomyosarcoma, it's origin different thing. Therefore, what is the point? It won't get bigger. Why? It's menopause. See, it's independent condition. That option is out. So, tricky point are whether you need MRI or reassurance. That's a problem because solitary is again a suspicious of sarcoma. Because sarcoma you won't get multiple. Sarcoma is a single one. Okay, again that option also there. Clear? Repeat the scan. There's no much value. If you suspect sarcoma, MRI. MRI. If it is not reassure, that's option. Okay, here. What is the option? So all the MCQs I asked Tumula to do, he did well, and he make some suggestions. Like here he want to add this married thing. I added that. Okay. 23-year-old married woman, polycystic ovarian syndrome, 9 months of amenorrhea, urine HCG negative, is not pregnant. TVS was thick endometrium. What is the best option? What recommendation you would? So how are going to explain this pathophysiology? This last one. How are going to explain the pathophysiology? Yeah, you know that. Polycystic ovarian, they have oligovulation, therefore they will be amenorrhea. Plus polycystic is a hypoestrogenic, hypoandrogenic condition. So they can have unopposed estrogen, endometrial will become thick. Then what else it can happen? So what is the answer here? What is the answer? C. Any other thing? Huh? What is the other thing? Endometrial hyperplasia. Now, unopposed estrogen, it can cause endometrial hyperplasia. So what is the answer? A. Answer A. A. True or false? The true false make it bigger, but A. That is true regarding polycystic ovarian syndrome management. But the meada baradu කරගෙන ඉන්න කිව්වට ඒක not okay. But it is a part of the management. B. LNG. LNG. Not contained there's a fertilization now. But here LNG, what is the place LNG? If biopsy confirms hyperplasia, then that is the hyperplasia without atypia. That is LNG is the best option. But here we don't have that much of evidence. D. Yeah, D, because she does not have bleeding and it's a part of the management of polycystic ovarian syndrome. But මෙයාට ඒක එච්චර වැඩක් නැහැ. E ඒක thickness එක වැඩිනේ. So what is the option? C. Endometrial biopsy, and we have to induce menstruation, because that's depend on the biopsy we can decide for the management. Okay, that's it. 9. Yeah.
9 months MBBS තියෙන නිසා නේද thickness එක වැඩිලා තියෙන්නේ.
ඒ නිසා තමයි.
COCP and
No. Thick endometrium, we don't know is it hyperplasia or proliferation. If it is
before doing endometrial biopsy we can start
no, then you don't have a diagnosis. No, endometrium is thick. So what are the possibilities? It could be just a proliferative endometrium, or it could be a hyperplasia. But hyperplasia, what is the problem? It can evolve into cancer. So hyperplasia OCP is a treatment. No. For the hyperplasia, we don't use OCP. No. If it is hyperplasia, we have to do the LNG or the noitestrone. Clear?
reconstruction එකේ amenorrhea හින්දා thickness එක වෙන්නේ.
Yeah, amenorrhea හින්දා තමයි thickness එක වෙන්නේ. Yeah, your answer, but we don't know the reason. Thickness, it could be a poly, unrelated thing, or it could be a just proliferation, it could be hyperplasia. It's clear. Yeah, definitely pilocytic. Yeah. Yeah, that's a tricky thing, age. But even a young patient, you can get endometrial hyperplasia. That's the problem with polycystic ovary. Chronic cannulation, generally they need menstruation for every 3 months. That is a that's the measure we are taking to prevent the hyperplasia. Here, best on is rather than treating blindly, because the bleeding ප්‍රශ්නයක් කියන්නෙත් නෑනේ. එයාට cycle regular කරගන්න ඕන කතාවක් කියන්නෙත් නෑ. Yes, OCP correct. But best one is we need to exclude abnormality. ඒක මම දැම්මේ නැත් ඒකයි. That's a tricky one. මම ඒක දැම්ම that is ඒක දෙමුනොත් ඒකද OCP තියෙන එක ප්‍රශ්නයක් වෙනවා. That's why yeah. No, what are the things we can achieve after now? Fibroid is a estrogen dependent condition. It's menopause. You will it grow? No. Can it transform into malignancy? No. Fibroid won't convert into sarcoma. Sarcoma is usually a different origin. Very rarely fibroid convert into sarcoma. Sarcoma is a venom. Okay. Yeah, these are the important things. The previous question, why Kalinkapika re-scan karan fibroid tibune kenagi? Because this is not working. Is there a place for re-scanning for fibroid in 6 months time? Here, there's no valid point here. Why? She is menopause. Fibroid is a estrogen dependent condition. Usually, it won't grow. Can it become sarcoma with time? Fibroid, can it become sarcoma? It's very rare. Sarcoma is a different origin. So, answer is there's no valid point. Clear? So, here the tricky one are the C O D. C is because of solitary thing. Sarcomas are usually one, solitary, not multiple. Yeah. Yeah. So, answer is, but sarcoma can features in the D. Anything you want to ask? Okay. Any suggestions? Madam, Google form. Was it effective? What do you want to do? Lecture time. Okay. Yeah. Okay, we can stop. 4th years, I think is hope final get some idea about the things. Okay, this is the pattern. This kind of MCQ will get practice. Okay, good night.